given that we've got so many female members of the audience, I thought I should talk about multitasking today. The first slide sort of alluded to where have we been and where we're going. Well, where have I been? It's nearly 30 years now since I came to Perth to get involved in the HIV scene, and it's been a very, very enjoyable time, and I think we've achieved a huge amount in WA. Where am I going? Well, I'm going to give up clinical practice at the end of next year. I think it's time. But I'm hoping to stay involved in research because I think it's quite an exciting time now. I think a number of us really think that there are ways of approaching a cure for HIV infection. So it'd be nice to stay involved. I was going to start off today by just going through a brief history of HIV as I've seen it at Royal Perth Hospital. Some of the dates here might be a bit rubbery. So it was around about 1984 I put there, but it may in fact have been 83 that the first AIDS case was managed at Royal Perth Hospital. Later in the 80s, and I can't find the date, even though I was involved in designing the immunodeficiency unit at Royal Perth, we can't find the date when we actually opened it. But later in that decade, we opened a specialised dedicated unit for managing people with AIDS. And thankfully, that doesn't exist anymore. We don't need it anymore. It's been fantastic to see how much things have changed. In 1994, we set up the Communicable Diseases Service to try and integrate the management of HIV and other sexually transmissible infections, and that service is still going and runs the sexual health clinic. In 1998, we set up a rural and remote service, and in 1999, a statewide group to help manage pregnancies in people with HIV. And it's those two particular programs that I really want to talk to you about today. But in bringing you this history, I think it's also important to stress that at Royal Perth Hospital, from the early 1980s right through to today, we've always been very involved in clinical trials and research. And I think that's what sets aside HIV medicine from a lot of other areas of medicine, is the dedication of people in the field to clinical trials and research, which has really changed the outlook for people with HIV dramatically over the last 20 to 30 years. So I want to start off talking a bit about HIV infection in the Aboriginal community, because I think this is something that would interest this group here today, and particularly focus on what we've done at Royal Perth Hospital. Now, if we look at rates of HIV infection in our Aboriginal community over the last 10 years or so, you can see that rates of infection are really not that much different to the general population. But what has concerned me and my colleagues at Royal Perth Hospital is that the outcome for Aboriginal people with HIV has not been quite as good as others, as the non-Aboriginal population. So, for example, if you look at the data from Royal Perth, I mean, we managed our first Aboriginal person with HIV at Royal Perth in 1984. Since then, we've managed about 90 people in total. And currently, we have an active cohort of 55 Aboriginal people. Now, you can see that somewhere we've lost 30 to 40 people with HIV infection. Some of those people we would have expected to have lost because many years ago treatments for HIV were not as good, but the number of people with HIV that we've lost, and a lot of them it's occurred because they've died, has been higher than we would expect. And the problem as we've seen it is that we cannot retain Aboriginal people with HIV infection in treatment programs as well as non-Aboriginal people. So These days, a lot of authorities around the world are thinking very, very hard about how we can reduce rates of HIV transmission and also prolong the life of people with HIV infection. And these points in the pathway of management have been identified. So clearly it's important to find people and test them, and a lot more testing is going on. That once you've made the diagnosis, then you need to link people into treatment programs, into care programs. But it's not just a matter of linking people into the programs. You've got to retain them in the programs. You've got to engage and retain them in the programs so that you can achieve lifelong suppression of the infection. Because this is not an infection that you can treat with a course of antibiotics and it goes away. It's an infection that people need lifelong treatment for, and therefore you have to retain them into treatment programs as well as engaging them in the programs in the first place. If you look at where Aboriginal people with HIV infection reside, you can see one of the problems that we've experienced in retaining people in programs. So you can see that just over a third of our Aboriginal people with HIV have been in the metropolitan area, but almost 2/3 have been in rural and remote regions. And this, of course, throws up big challenges. And to address this challenge, what we did in Royal Perth Hospital, as I say, back in 1998, was that we set up a rural and remote service. And this was a service that was run through the Departments of Clinical Immunology and also the Department of Infectious Diseases at Royal Perth Hospital. We established a nurse coordinator who has been absolutely crucial in the successful running of this program. And this coordinator can provide advice and support for not only people with HIV, but also the health professionals that are managing them, nurses, community workers, and doctors. That person can arrange clinic appointments and medications. And also through the program, we've also run regional clinics as well. And that's been a really important part of the program. I think patients respond to you a lot better if you go to their environment and talk to them in their environment. Also, it's given us the opportunity to undertake education programs for staff in the various areas that we've gone to. And I for one, have enjoyed that very much over the years. Here you can see a group of us, as a motley-looking lot, following one of the clinics that we did in the Gascoyne some years ago. And there on the picture you can see on the far left Marissa Gillies, my colleague, who's a population health physician, who's done so much good work in the Gascoyne region, and next to her Ali Kane, who's been the coordinator of the rural remote service since it was set up. Now, we believe that we've obtained very good results by setting up this service and the pregnancy service, which I'll talk to you about next. And we've achieved engagement of people in treatment programs. So of the 55 active patients now managed through Royal Perth, and I'd have to stress there are some managed through Fiona Stanley Hospital, but I've got the data for those managed through Royal Perth. We've got 93% engagement now of people in the program. We go out of our way to give individualised treatment programs. We realise that the traditional outpatient model of giving someone an appointment and expecting them to turn up on the day often doesn't work for people for Aboriginal people, and indeed other people in our community who have a disadvantaged lifestyle. So we strive to have individualized treatment programs, and basically we'll see anyone whenever they turn up. And we've got to use that sort of model of treatment. And we've tried to develop multidisciplinary teams that are patient responsive. So we've engaged a network of population health physicians in the regions, nurses and Aboriginal health workers. We have physicians in Perth, such as clinical immunologists and infectious disease physicians, who are willing to advise and give advice by email from Perth, but also to travel to regions and do clinics. We've got specialised HIV nurses involved, and also social workers. And some of our social workers have been absolutely invaluable in helping people with their social problems, because if you can't sort out the social problems, you're not going to engage people into medical treatment programs. So social workers have been absolutely crucial in our programs. So we have achieved about, say, 84% of people engaged in the program have been on antiretroviral therapy, which is not far off of the general population. About 90% of people in our clinics are actively engaged in antiretroviral treatment programs. And when we look at a measure of success of antiretroviral therapy, that is the number of patients who've got undetectable viral load, then it's around about 60% of Aboriginal people achieve that. That's a little less than we would hope for. Most people in our clinics, about 90% of them have got undetectable viral load, but it's a lot better than it used to be, and we're getting better. We're getting better. I think what we're particularly proud of, though, and these are the data that I especially wanted to show you today, was what we've achieved with pregnancies. As you know, untreated pregnancies, untreated pregnancies result in about 1/3 of babies acquiring HIV infection from transmission from the mother. But that can be prevented by giving the mother antiretroviral therapy. And over the years, and certainly since we set up the rural and remote program and the pregnancy management program, we've at Royal Perth have managed 32 pregnancies in Aboriginal women with HIV infection, the majority of whom are from rural and remote areas. So many difficulties in managing those pregnancies. 29 of those pregnancies have been managed by a multidisciplinary pregnancy management team that we set up years ago, and only 3 have been unmanaged. Now, this multidisciplinary pregnancy management team is illustrated here, and you probably can't read it, but basically we've got a team that consists of our rural and remote service coordinator. We've got physicians, social workers, we've got paediatricians, obstetricians, neonatologists, midwives, you name it, we've got them. But it's a big team. The team meets regularly to discuss every pregnancy and how that pregnancy is managed. We've developed standardised protocols for managing the mothers and the babies, and we've achieved I think, excellent results. So, at the time of delivery, we've ensured that over 70% of mothers have an undetectable viral load. And again, I stress that the great majority of these women live in rural and remote areas. The median CD4 T cell count, which is a measure of the success of therapy as well, was over 500, which is normal. When we look at delivery of babies, then I think it's important to point out that all deliveries, or virtually all deliveries, have been done at King Edward Memorial Hospital. Now, this is not an ideal situation for many Aboriginal women having to come down to Perth to give birth at King Edward Memorial Hospital, but we've built it into our protocols. It has been accepted, and I think it's been one of the main reasons that we've got such good outcomes. So over 80% of the deliveries have been by vaginal delivery. We've never believed that it was important to undertake caesarean section unless there was an obstetric indication. So 17% have been by caesarean section. And here you can see the outcomes. So of the 29 full-term pregnancies that we've managed, only one baby has acquired HIV infection, so 4%. That, I think, is a really excellent outcome for Aboriginal women with HIV infection. Of the patients who were unmanaged, and they were unmanaged for reasons beyond our control, one of the two women has had a baby with HIV infection. And I think what was particularly pleasing was that there have been relatively good long-term outcomes as well for the babies and for their mothers. So of the babies that were born to the affected women, 90% have remained with their mothers, while 10% have had to have involvement from Department of Child Protection. So what we've learned over the years that we've been running the Rural Remote Service and the Multidisciplinary Pregnancy Management Service is that excellent treatment outcomes can be achieved for Aboriginal people with HIV infection. We've also learnt that engagement and retention of Aboriginal people in HIV care and treatment it can be enhanced by investment of time and money. So as you can imagine, the services that we've run, the Rural Remote and the Pregnancy Service, have involved a lot of time and effort from the staff involved, but it's worth it. If you invest that time and money, you get good outcomes. That we realise that culturally appropriate and holistic care is important for Aboriginal people with HIV, and it's been so important to have a multidisciplinary team approach involving not only medical and nursing staff but community health workers and social workers and midwives, everyone involved. That's been, I think, critical. And then I sort of come on at the end of the talk to the other bit of what I was going to talk about this morning, what I was asked to talk about, and that's the research that we've been doing. And don't worry, I'm not going to go into a long diatribe about immunology, but I just thought I'd tell you a little bit about some of the research work that we're doing and think about the future. So, in managing people, Aboriginal people with HIV infection, new approaches to therapy would certainly help. Advances are definitely being made in the development of long-acting injectable antiretroviral drugs. So in drugs that you can give by an injection, say once every month or once every 3 months. There's a lot of advances being made in that. But wouldn't it be good if we had a vaccine that you could use to actually boost immune responses against the virus and suppress it permanently so that you don't need to use antiretroviral therapy at all, and possibly even use a vaccine like that to cure the infection. And that's what a lot of HIV research is focusing on these days. So what are we trying to do in HIV cure research? So this sort of summarizes it in one slide. You all know that if you treat someone with HIV with antiretroviral drugs, you can suppress the infection for years. I've got people I've been looking after for over 25 years now who've been on antiretrovirals all that time, and you can suppress the infection, but they've got to take treatment every day. Also, we know that you cannot get rid of this virus. It integrates itself into the genetic material of cells in the immune system, and it sits there. It's latent. And as soon as you stop the treatment, bang, it just comes back again. You can't get rid of it. So there's a lot of research going on, as you see at the bottom of the slide there, to develop drugs that will push the virus out of this latent state and make it more active again so that you can attack it in other ways. Interestingly, one of the recent drugs that's been shown to push HIV out of latency is a drug called Antibodies. Now, for those of you who are my age and even a bit younger, you probably know about Antibodies. Antibodies is a drug that was used to treat people with alcoholism. If you take the drug and you drink alcohol, you throw up. For some reason, who knows why, it actually drives HIV out of latency in cells. And there's been a trial done recently in Melbourne and San Francisco. They published it a month or two ago where they showed that this drug actually can drive the virus out of latency. So once you've got it out of latency, what do? Well, then you've got to hit it with something, what the Americans call the kick and the kill approach. And one way of hitting it and killing it might be to intensify your antiretroviral therapy, as shown on the left there. Well, the answer is we know that that approach just doesn't work. It doesn't matter how many new drugs you throw at people, you can't seem to get rid of the virus. So what about using interferon alpha therapy? All of you will know about interferon alpha because it's used to treat hepatitis C infection, and in some people with hepatitis C it can actually get rid of the virus. Well, there is in fact some data to show that interferon alpha can actually suppress the amount of HIV, and so there's interest in possibly using that as well. But alone it's probably not enough. So there's a lot of interest in developing, as you see on the far side of the slide there, a vaccine that you can use to boost immune responses against HIV to try and control it. Now, if we're going to do that, we've got to develop a vaccine that will hit HIV where it lives most of all. And this is an immunodeficiency virus. It lives in cells of the immune system, and it particularly lives in cells in the lymph node. And here on this slide, you can see there on the left-hand side, at the top of the slide, a lymph node, say a lymph node under your arm, and this is particularly where the HIV virus resides. Even in people on antiretroviral therapy, you just cannot get rid of these viruses completely from lymph nodes. And here's a picture of a lymph node of someone with HIV taken with an electron microscope. Now, for Corey, where's Corey? And people of her age, which there's a few of you in the audience, you probably wouldn't know that this was the first picture of the HIV virus ever published, okay, in a human tissue. And this work was done at Royal Perth Hospital, right? So many people don't know that. So the first time that the HIV virus was ever shown in human tissues was at Royal Perth Hospital. So there on the far side there you can see those little blobs. That's the HIV virus budding off of cells where it's coming out of the cell. Okay, and here on this side of the slide, on the left-hand slide, looking at it, you can see lots of tiny little black dots, and that's the virus stuck in this area of the lymph node where it tends to replicate. So what people have been trying to do with vaccines is to develop immune responses that will attack that virus in those lymph nodes and other parts of the body. And I don't want to go into too much detail, but just to give you in 3 slides in fact, a broad overview. So the main thrust around the world is to make vaccines that will produce antibodies against the outside of the virus, those little pegs on the outside, which are called the envelope. And the trial that was done in Thailand and published some years ago, where they actually showed the RV144 trial, where they actually showed some effect of the vaccine. That vaccine generated these antibodies that bound to the outside of the virus. The trouble with the envelope of the virus, the outside of the virus, is that the virus is always changing it. The genes for that part of the virus are mutating all the time, and it's constantly changing. A bit like the flu virus. The flu virus mutates. And that's why we have to have a different vaccine every year, because it keeps changing its coat, its outside coat. Well, the HIV virus does that even more, does it a lot more than flu. But the inside of the virus, the core of the virus, you can see there that green bit, that doesn't change anywhere near as much. And so there's been a lot of effort to try and focus immune responses on that part of the virus. And in fact, we know that T cells, type of immune cell against that part of the virus, there's lots of research over many years to show that they're strongly associated with control of HIV infection. But our research has been looking at the role of antibodies. So here I've just summarized the main types of immune response against the virus. So there may be antibodies that bind to the outside and neutralize the virus. There may be antibodies that bind to the outside of the virus and stimulate other cells to kill the virus-infected cell, what we call NK cells. But we're working on the one on the bottom, on the far right-hand side, and I won't go into what it means, but it's a particular type of antibody response that really no one else is looking at very much at the moment, and we've focused on that one. And these are data from a paper that we published earlier this year, and we're very excited about these data, because what we've shown is that the higher the amount of antibody you have, so the higher up here, the lower the viral load. So these are all patients who are not receiving antiretroviral treatment, and the more antibody the patient has in their blood, the lower the amount of viral replication. And this is the first study to actually show that this particular type of antibody seems to be involved in controlling the infection. So we're very excited about this, and we're going on now to study more groups of patients and just trying to work out if there are ways in which this type of antibody response could be stimulated with a vaccine. So in finishing, I'll just draw your attention to this motley bunch here. This is a group that we set up a couple of years ago, 2 or 3 years ago, which is called the Gumbuya group. This is a group of people from around Australia, and we meet once or twice a year to try and discuss ways in which we can improve treatment uptakes of people, Aboriginal people with HIV infection, and the retention of Aboriginal people in treatment programs. And I hope that over the next few years we will bring treatment of Aboriginal people with HIV infection up to what we expect for the general population. And I also hope that within the next 5 to 10 years we may in fact develop an HIV vaccine that will lead to a cure of HIV infection, and we won't need this sort of group. Thank you very much.